The basic function of cardiac resynchronization therapy devices is the resynchronization of ventricular function. A characteristic feature of classic CRT devices is the presence of a left ventricular lead in addition to the right ventricular lead. The left ventricular lead is conventionally inserted through the coronary sinus into the venous system of the heart, usually in the posterolateral left ventricular region. The goal of ventricular resynchronization therapy is to achieve the percentage of biventricular pacing as close as possible to 100%. The chest X-ray shows the patient after implantation of the CRT-D device, which in addition to the ventricular resynchronization function also has the function of an ICD device. It is worth noting that this patient also has a lead placed in the right atrium, which allows maintenance of atrioventricular synchrony. Cardiac resynchronization therapy is important in the treatment of heart failure patients with a left ventricular ejection fraction equal to 35% or less despite optimal pharmacotherapy. Among them, the main group of patients who may benefit from this therapy are patients with left bundle branch block. In these patients, cardiac resynchronization therapy is recommended if they have symptoms of heart failure, are in sinus rhythm, and have QRS complexes with a duration of at least 130 milliseconds. On the other hand, in heart failure patients with left ventricular ejection fraction equal to 35% or less, despite optimal pharmacotherapy, CRT should or may be considered if the patients have symptoms, are in sinus rhythm, have a QRS complex duration of at least 130 milliseconds, and their morphology is different from left bundle branch block morphology. In addition, CRT rather than right ventricular pacing is recommended for heart failure patients with reduced left ventricular ejection fraction irrespective of New York Heart Association class who have an indication for ventricular pacing and high degree atrioventricular block. CRT therapy should also be considered for patients with left ventricular ejection fraction equal to 35% or less in New York Heart Association class 3 or 4, despite optimal pharmacotherapy, to improve symptoms and reduce morbidity and mortality if they are in AF and have a QRS duration of at least 130 milliseconds, provided that a strategy to ensure biventricular capture is present or the patient is expected to return to sinus rhythm. Furthermore, heart failure patients with reduced left ventricular ejection fraction who have had a conventional pacemaker or an ICD and develop worsening heart failure despite optimal pharmacotherapy and who have a high rate of right ventricular pacing may be considered for upgrade to CRT. This recommendation does not pertain to patients with stable heart failure. It is worth remembering that CRT is generally contraindicated in patients with a QRS complex duration of below 130 milliseconds. In the group of patients undergoing CRT therapy, those with left bundle branch block, longer QRS duration, ischemic cardiomyopathy, and women may benefit the most. These are patients who usually respond favorably to CRT, the so-called responders. Slightly lower benefit from CRT is observed in men and patients with ischemic cardiomyopathy. In contrast, patients with narrower QRS complexes and intraventricular conduction abnormalities with a morphology other than LBBB usually do not respond favorably to CRT. These are the non-responders. In patients with heart failure and sinus rhythm, numerous randomized clinical trials have shown a beneficial effects of cardiac resynchronization therapy. It has been demonstrated in these patients that the use of CRT can lead to improved quality of life, increased left ventricular ejection fraction, improved New York Heart Association class, reduced hospitalization rate, and reduced total mortality.